Good afternoon, everyone. Glad to see folks joining us this evening. We have a very interesting topic today. It is called PCOS and Insulin Resistance. Our speaker is Dr. Yates Knowlton from South Carolina OBGYN and Associates. I'm going to turn it over to Brianna to let her give a full introduction of Dr. Knowlton, and then we will begin. Take it away, Brianna.
Okay, so I personally chose Dr. Knowlton because he actually diagnosed this for me personally, and he has an extensive background in PCOS and working with any sort of disorders like this. It can be anything gynecology, or it can be any sort of reproductive issues.
Thanks, Brianna.
Yeah.
So again, I'm Dr. Knowlton. I'm one of the OBGYNs over at South Carolina OBGYN Associates. We're over in Medical Park 1, kind of connected to Lexington Medical Center. And so this is probably a different perspective than a lot of your talks, just because I am an OBGYN, but I think it's got a lot of pertinence to people with diabetes and insulin resistance as well. Happy Tuesday to everybody. Again, we're OBGYN, so we see a lot of fun deliveries and things like that. The babies who were delivered today got special Tuesday onesies. And we even had 3 sets of twins get delivered today. So a busy day up on the labor unit. So what we're going to talk about today is PCOS and insulin resistance. PCOS is polycystic ovarian syndrome. So first we'll talk a little bit about what exactly PCOS is and how we diagnose it. We'll talk about the implications of people who have PCOS or who are diagnosed with PCOS. And then we'll talk about the relationship between PCOS and insulin resistance. And then get in a little bit to the treatments of PCOS. If y'all have any questions, I'm not great with computers, but if you want to chime in with any questions as we go along, please feel free to do so. So PCOS is been around forever. Some of the earliest, or one of the earliest quotes about PCOS was from Italy. This guy Antonio Valacirni described young married peasant women who were moderately obese, infertile, with 2 larger than normal ovaries that were bumpy and shiny, just like pigeon eggs. And as you'll see as we go along, he kind of hits on a lot of the different factors with PCOS, even though they didn't have a defined syndrome at that point. That includes metabolic issues, fertility issues, and then the ovaries that are describing are kind of the classic polycystic appearing ovaries. In the 1930s, there were these 2 guys down here, Dr. Stein and Leventhal. And they were both in Chicago, and they were the first ones to really describe a group of patients with what we now call PCOS. At the time, they called it Stein-Leventhal syndrome, which was sort of, I think, particularly remarkable because there was no ultrasound available at that time. But they described these women who didn't have regular cycles, had some issues with acne and hair growth, and they actually operated on these women and took part of their ovaries out and were able to help them achieve pregnancy. Things sort of took off by the 1980s with ultrasound technology, and that's when we started to have access to modern ultrasound, and we're able to take the kind of pictures that we can take now, and that really helps us see people's ovaries. And could help sort of make this diagnosis a lot similar. And then in 1990, for the first time, there was a conference with a group of experts at the NIH, and they tried to give diagnostic criteria to make the diagnosis of PCOS for the first time, so that people would have sort of standardized definitions. At that point, they were not using ultrasound findings in the diagnosis. I think largely because ultrasound was still sort of coming along and maybe not readily available in all places. And so that led up to 2003, which doesn't sound like it was so long ago. And that's when there was a big conference in Rotterdam, kind of an international conference with all the different PCOS experts. And they redefined the criteria to make the diagnosis of PCOS. And that's kind of the method that is still the most used today. So Rotterdam is a city up here in the Netherlands, kind of south of Amsterdam. It looks like kind of a nice place for a conference, but I think any medical student or OBGYN that you talk to is familiar with sort of the Rotterdam criteria. And so these are criteria to meet the diagnosis of PCOS, but you have to have 2 of 3 things. So one is oligo or anovulation. So that means people don't, release an egg to try to get pregnant every month. And the way that usually manifests, of course, is people that have irregular menstrual cycles, have signs or lab evidence of high androgen levels. And we'll talk about those later, but androgens are kind of the male hormones like testosterone and DHEAS that are higher than they're supposed to be in women. And then the third is the actual polycystic appearing ovaries. And usually we use the ultrasound to kind of diagnose those rather than what Stein and Leventhal were actually operating on these patients, a long time ago. And then you can't have another disease that explains the symptoms that the patient has. And so it's really a pretty simple diagnosis to make at this point, but one that probably is not made frequently enough, I think. So there's been some pushback about the actual term polycystic ovarian syndrome. And I think it's probably not the best name for the syndrome for a couple of reasons. We'll look at some ultrasound pictures in a minute, but the actual cysts in polycystic ovarian syndrome are not true cysts. They're just immature follicles that are normal. They're just present in abnormal amounts. In other words, there's way too many immature follicles, and the fact that there's a follicle itself is not a problem. It's just the fact that there's so many. So there's not truly a cyst with polycystic ovarian syndrome. And the other thing is you don't actually, if you look back at the criteria, you don't actually need polycystic ovaries to be diagnosed with it. So if someone has a high testosterone level and irregular cycles, that would be enough to diagnose them with PCOS, even if they have ovaries that look pretty normal. So there's been some push to rename it the metabolic reproductive syndrome. I think that probably better fits or better describes the syndrome. But it's tough to gain momentum when everybody in the world is using one particular term. The other thing I'll point out is that PCOS is very common. Probably 5 to 15% of the world's population has PCOS. Again, I think it's for sure underdiagnosed, and the incidence seems to be increasing. That's probably related to lifestyle factors like sedentary lifestyle and diet, and we'll get into some of that here in a little bit. All right, so we're going to talk a little bit about the criteria for PCOS in a little bit more detail. But again, oligo-ovulation. So oligo means few, and ovulation is the act of sort of releasing an egg to try to get pregnant. So basically that means that you aren't ovulating often enough. And again, people don't really know when they ovulate, but they know when they have a menstrual cycle. And so most people will complain of cycles every few months instead of every month. Sometimes the cycles can be heavier or prolonged because that endometrium's had a longer time to grow, and the bleeding can be sort of unregulated. Some people have just prolonged bleeding, and sometimes that's just from the disordered growth of the endometrium, and we'll sort of look at pictures of that in a minute. And then some people come in and say, I just don't have cycles at all, which I think is not safe and not a good thing, and we'll talk about the reason why. The oligo-ovulation is responsible for the decrease in fertility in people that have PCOS. You can imagine if you have a 20 or 25% pregnancy chance per ovulation, if you only ovulate 3 or 4 times a year, it's likely that you'll have trouble getting pregnant, just statistically. And this is the most common way that people present, at least in my practice. It may be different in internal medicine or family medicine office, but in my experience, most people come in with complaints of cycle issues, whether they're too far apart or having prolonged or heavy bleeding or something like that. Probably second most common reason people come in is difficulty getting pregnant. All right, and we talked a little bit about the signs of hyperandrogenism. So again, androgens are male type hormones like testosterone. These are made in excessively high quantities in the ovaries of people with PCOS and tend to cause acne and abnormal hair growth. So this is a picture I took off of Up to Date, which is one of our references that we use, and you can see the kind of the oily skin and the acne like complexion. I think chin hair is the most common area that people will complain of abnormal hair growth. Some people have chin hair that runs in families, but if it doesn't run in someone's family and someone has kind of abnormal appearing chin hair, usually we'll look at PCOS as a likely reason why that would be. All right, and then the third criteria again is the polycystic appearing ovaries. I know probably most of you don't look at many ultrasound pictures, but this is from someone in our office. And just to get you oriented here, this is the uterus is in this area. All right, and then this is one of the ovaries. I'm not sure if it's the right or the left ovary. And all of these little, can y'all see my mouse? I hope so. So all of these little, yeah. Okay, good. All these little black dots are little immature follicles. And those are the cysts that we talk about with polycystic ovaries. So there's 2 kind of classic appearances on ultrasound that I think are kind of cool. I guess sort of in a nerdy way, but one is the string of pearls finding. And so you can imagine this almost looks like a pearl necklace. You really use your imagination. All right, and then this is from another patient, and you can see just lots and lots of these little immature follicles, which are abnormal. I didn't include a normal picture here, but usually, we'd see maybe 3 or 4 little follicles on an ovary. You can see in this patient, she's got tons and tons of follicles, which is not normal. All right, so again, those are sort of the diagnostic criteria, and you don't have to have all 3, you just have to have 2 of 3. So typically if someone comes in and we're suspecting endometriosis, we'll do some lab workup, especially to check the androgen levels, to kind of rule out other things that can mimic some of the signs of PCOS. And then we'll check an ultrasound and see if the ultrasound findings are kind of consistent with the syndrome. No one really knows what causes PCOS. We think it's probably multifactorial. I think you need to keep in mind that it's a syndrome. So syndrome is kind of a collection of characteristics rather than necessarily a disease caused by the same thing. Again, I think genetics probably play a bigger role than anything else. There's been some evidence that maybe the prenatal environment can expose someone to have PCOS, and then certainly lifestyle effects can make someone more likely to develop the syndrome, similar to insulin resistance or like type 2 diabetes or something like that. When I think about PCOS, I usually think about a few different groups of implications. So the first we'll talk about are there reproductive implications. Then we'll talk about the sort of the gynecologic implications, and then the metabolic implications, and we'll get a little bit more in depth with those. But again, this is probably the second most common reason that people present to my office is complaining of, hey, I've been trying to get pregnant for a year, and my cycles are irregular and I can't get pregnant. So again, I think ovulation is the problem. We talked before, if you have a 20 or 25% pregnancy rate, if nothing else is going on per ovulation, that's great if you ovulate 12 times a year, but if you only ovulate 3 or 4 times a year, odds are you're going to have difficulty getting pregnant. I think I'll talk about this a little bit later in the slideshow too, but usually the fertility issues can be overcome. We know that weight loss can help with ovulation. Metformin can help make it more likely that people ovulate. And then ovulation induction with medicines like letrozole really do a very good job and can get patients with PCOS to ovulate a lot more consistently. I think it's important to realize, especially when patients come in and they want to be pregnant, last year, that people with PCOS are at higher risk in pregnancy too. So it's good to know that ahead of time. Some of this can be managed by optimizing health before pregnancy, and some we just know is there, and there's not much we can do about it. But people with PCOS are at higher risk of having miscarriages, much higher risk of having gestational diabetes, higher risk of preterm birth, and higher risk of requiring cesarean section for delivery. I usually will draw a little pelvic model. This is one I took just off the internet, but I think it's important to kind of know what the process is supposed to be like and what it's like in PCOS. So in someone without PCOS who has normally functioning ovaries, if they started their menstrual cycle today, okay, so you'd have bleeding coming from the uterine cavity through the cervix and out the vagina. The ovary in the first part of the menstrual cycle is making mostly estrogen. Okay, and estrogen is like fertilizer for the endometrium. So it tells the endometrium to grow. After a few days, the endometrium grows enough that the bleeding stops, and that's when the cycle stops, of course. And then after about 2 weeks, the ovary releases an egg from a follicle. The follicle makes a jump from being an immature follicle to a mature follicle and gets a lot larger, and that's something that we can see on ultrasound. But more importantly, it sends a signal to both of the ovaries and tells it to quit making so much estrogen and to start to make more progesterone. And progesterone is the pregnancy hormone, but it thins the lining of the uterus out and tries to get it ready for a pregnancy. If someone gets pregnant before their cycle starts, then the pregnancy starts to make the progesterone. If they don't get pregnant, that follicle sort of dies and goes away after about 2 weeks. And when that happens, when the progesterone level drops, that's when the next cycle starts. So the big problem in PCOS, and the reason why people don't have regular cycles, is they're sort of stuck in the first half of that process. So there's all these little immature follicles that are sending the signal to make estrogen. The estrogen's telling this to grow and grow and grow. So there's an estrogen progesterone imbalance in people that have PCOS. And the problem with having all that estrogen around and not enough progesterone is that signal to grow and grow and grow can cause abnormal growth and eventually uterine cancer. Fortunately, there's an easy fix early in the process. If we get someone on some sort of progesterone to balance out the estrogen, that is very effective at preventing endometrial cancer. And that can be anything from a birth control pill. Sometimes we'll do cyclic sort of progesterone every few months if someone doesn't want to take something long term. There's the progestin IUDs like Mirena and Kyleena. And then the next one on is the injectable progesterone rod that goes in the arm. Depo-Provera would be another option. We don't use as much Depo-Provera now as we did 10 or 12 years ago. All right, and this is just an example of that. Again, I know I look at ultrasounds more than most people, but this is sort of the outline of the uterus here. All right, and so from the last picture, remember we have a uterine wall that's got a muscle, and that's sort of this darker area. And then we've got this bright white area is the endometrium. This is a patient who is postmenopausal in her 60s with a long history of PCOS and abnormal bleeding that wasn't treated. So she didn't cycle very frequently. Unfortunately, this endometrium had gotten really thick and ended up being an endometrial cancer. Endometrial cancer is one that usually is pretty treatable. So she went to a GYN oncologist and had her uterus and lymph nodes taken out. And I believe she got chemotherapy, although not everybody with uterine cancer does need chemotherapy. But again, I think this was probably an avoidable cancer if this patient had been on progesterone, early in her reproductive life. All right, and then the metabolic consequences of PCOS are very significant. So we know that there's a high correlation between PCOS and I think PCOS and impaired glucose tolerance or insulin sensitivity are pretty similar, but there's a 5-time increased risk of that in patients with PCOS versus patients that don't have PCOS. A 10% chance of getting diabetes by age 40. And I think that's, 40 is pretty young, I like to think, since I'm pushing 40. And that's really high, I think, 10% by age 40. And then increased risk of other metabolic issues like high cholesterol, high blood pressure, metabolic syndrome. We used to talk about that a lot, and they probably still do at the internal medicine office, but you need 3 of those 5 things, including increased waist, circumference, high blood pressure, abnormalities with different lipids, and elevated fasting glucose. And we think that most of these metabolic consequences are a result of insulin resistance. So insulin resistance is basically defined as an abnormal or subnormal response to a normal amount of insulin. So in other words, if we gave someone a dose of insulin that should be enough to keep their blood sugar low, and they don't respond the way that we expect them to, we would say that's insulin resistance. There's no real standardized way to measure it, so it's sort of hard to make the diagnosis or do any studies about it. But there's a lot of different causes. Some people have inherited issues. Sometimes weight can play an issue in it. Stress, inactivity, different medicines. Pregnancy, that's why we make everybody do a glucola while they're pregnant. Immune issues. I think PCOS is sort of a chicken or the egg sort of deal, whether PCOS causes insulin resistance or if insulin resistance causes PCOS. And then I think in most people, it's sort of a multifactorial issue. In other words, there's no one clear cause for why most people have it. But you can see here, 50 to 75% of people with PCOS have insulin resistance, which is, just astronomically high. The mechanism for why PCOS causes insulin resistance, or the other way around, has not been well defined. There's a lot of active research going on in this area. This is a slide from the University of Oregon, one of the labs who's sort of studying it, but no one really knows why the two are so related. I've heard from different reproductive endocrinologists about 4 different proposed methodologies for why the two are related. But I think no one really knows for sure why at this point. And again, I think it's sort of I don't know if one necessarily causes the other, or if they're just 2 different manifestations of the same disease, but they're definitely very closely related, and a lot of people with one have the other. So the consequences of insulin resistance, of course, number one is going to be diabetes. But I think insulin resistance can also cause other parts of the metabolic syndrome, like high blood pressure, cardiovascular disease. And then again, we talked about, whether it causes PCOS or whether it's just a different manifestation of the same disease process. So next I want to talk about sort of interventions and the way that we kind of manage PCOS or treat PCOS. And I think to do that, it's important to sort of talk about different places to intervene. So I think in an ideal world, we would stop things here and sort of prevent PCOS, but that may be difficult to do. A lot of what we end up doing is finding people that have PCOS and then trying to manage them so that they don't end up with significant insulin resistance or worse, diabetes or metabolic syndrome down the road. And this is sort of a similar chart, just in a different order. So people with insulin resistance, can we prevent them from getting PCOS? And then people with PCOS, can we prevent them from getting infertility and endometrial cancer and hyperplasia? So can PCOS be prevented? So I think that's sort of impossible to answer. I do think that some cases are probably preventable with lifestyle changes, and I think that's why, with an increased sedentary lifestyle worldwide and in a Western diet, I think that's why we're seeing increased case numbers. But it would be kind of impossible to prove that something could prevent PCOS, because you'd have to have a lot of subjects. You'd have to pick we'd probably be talking about a lifestyle variable. So, it's hard to randomize people to, this group of people does exercise for years and this group of people doesn't. It would take a long time for any intervention to prove that it prevented something. And then there'd be so many different confounding variables. So I don't think we can ever prove that PCOS can be prevented. I do think there's a role for diet and exercise, and we'll talk a little bit more about diet in another slide, and exercise as well. But we do know that in people that have been diagnosed with PCOS and have ovulation problems, if they lose 5 to 10% of their body weight, a lot of these people will resume ovulating and having regular cycles. I've been asked before, does that mean their PCOS is gone? I never quite know how to answer that question, because technically they may not meet the criteria for it, but they're the same person that they were when they had it. So I think they probably still have the same phenotype. They just aren't currently manifesting the disease. So I don't think it really goes away, but they may not meet the criteria for it going forward. I think it's kind of similar with diabetes. If somebody does really well with their diabetes and their A1C is completely normal, and they get to come off medicine, does that mean they don't have diabetes? I probably the same sort of deal. I'm not sure what the real answer is. So can insulin resistance be prevented in people with PCOS? So I think it's important in people that have PCOS to get screened frequently for insulin resistance and metabolic syndrome. So we'll do, diabetes screens at least every other year. Same with lipid panels and check blood pressures as well. Again, we alluded to diet earlier. I think most of the data shows that the caloric intake is probably the most important part of diet, rather than recommending one specific diet over the other. In general, though, I think a diet that's low in simple carbohydrates, so like a low glycemic index food or diet would be helpful. A diet that's high in protein, and a diet that's low in unprocessed foods, or high in unprocessed foods. And then again, avoiding simple carbohydrates and processed foods is probably the best, in a nutshell, the best diet for preventing metabolic problems with PCOS. And then I think regular aerobic exercise is definitely important. I tell people a goal ought to be 30 minutes of aerobic exercise 5 days a week. I think weight training is very helpful too, but probably not quite as beneficial as aerobic exercise. Weight loss, I think, is crucial, or maintaining a healthy weight is crucial. I don't really love talking about weight, but all of the best data for preventing metabolic issues with PCOS seems to come back to weight loss and maintaining a healthy weight. And then metformin, probably doesn't prevent insulin resistance, but it can help manage insulin resistance and possibly prevent diabetes. All right, so can decreased fertility be overcome in PCOS? And we sort of talked about this earlier, but fortunately the answer seems to be yes. So again, I think it's important that we make sure we optimize someone's health before they get pregnant. Weight loss, if someone's overweight, 5 to 10% of body weight often will cause menses to resume and cause ovulation to resume as well. And so some of these people, if they lose weight, can achieve pregnancy without really any medical intervention. Metformin can increase ovulation rates in some people with PCOS. And again, ovulation induction is very effective in getting someone to ovulate and ideally achieving pregnancy. There's 2 different ovulation medicines. Clomid's probably the one more people know about. We don't use that as often in people with PCOS because of the twin rate. Again, there are a lot of twins today. I don't know if any of them took Clomid, but the twin rate with Clomid is about 7% versus letrozole seems to have as good or better pregnancy rate. The twin rate's only about 4 or 5%. So most people are using letrozole now specifically for people with PCOS. All right, and then can uterine cancer and hyperplasia be prevented in patients with PCOS? Again, I think this is maybe the most important thing, at least from an OBGYN standpoint, is that yes, these cancers are largely preventable. Again, the key is to counteract the estrogen with some sort of progestin. We kind of talked about these earlier, whether it's a cyclic oral progesterone, birth control pills, progesterone pills, IUDs, or the implantable rod. And these are all, pretty well tolerated, and again, can help prevent cancer in most of these cases. And then the symptoms of increased androgens we talked about before. So the 2 common ones that we see frequently are acne and facial hair growth. Putting someone on systemic hormones like a birth control pill can help with acne. It increases the protein that the androgens bind to, and that counteracts the effects of the testosterone and the other androgens. There's another medicine called spironolactone that's a mild diuretic that also has some androgenic properties. So we'll put a lot of patients on that, and that seems to do pretty well and is pretty well tolerated. And then beyond that, it's kind of normal dermatology stuff, whether it's face washes or Accutane, different things like that are typically used for acne. And kind of the same for hair growth. The unfortunate thing about hair growth is it's hard to reverse. So if we put someone on birth control pills and spironolactone, again, that does a pretty okay job at preventing any new chin hairs from forming. It's not very effective at making hairs that are already present sort of resolve or go away. And so a lot of people, if this bothers them, will choose cosmetic treatments, whether it's laser hair removal or waxing or different things like that. All right. So again, just to kind of recap, I think PCOS is important because it's more than just a fertility disease. I think a lot of times when people are talking about it, they talk about it with its infertility implications and maybe not as much with the metabolic implications. Again, I think aerobic exercise, balanced low calorie, low carbohydrate diet, and maintaining a healthy weight are the most important things you can do to avoid the metabolic complications of PCOS. And again, I can't stress enough that endometrial cancer in people that have PCOS is largely preventable with progestin therapy that usually is pretty well tolerated. All right. And this is our baby girl who is coming next week. So we're excited for a second baby girl and my wife's third baby. Does anyone have any questions or anything they wanted to talk about?
Congratulations on the baby.
Thanks. I'm trying. I'm not able to get out of this screen. There we go. Well, thank y'all for joining the talk. We're around if anything comes up or if any questions come up. Again, I think this is an important topic for people that have diabetes or even people that have PCOS. And again, I think a lot of these complications are sort of avoidable. All right.
Thank you so much, Dr. Knowlton.
Thank you.
This is a great presentation, and congratulations again.
Thank you. Y'all have a good night.
All right. Thank you. You too.
Thanks.
Thank you.
Thank you.
Good night, everyone.